Glenohumeral osteoarthritis is classically characterized by pain, weakness, and restricted motion. Non-operative treatment modalities are often effective in minimizing associated symptoms and maintaining quality of life. If these measures fail, glenohumeral arthroplasty is shown to provide substantial relief in older populations. Much of the published literature, however, involves older patients with lower functional demands. The optimal treatment of glenohumeral arthrosis in young patients is yet to be firmly established. Young patients who are active laborers or have recreational interests that place high demands on the glenohumeral joint are perhaps less optimal candidates for current arthroplasty options. Arthroscopic management of glenohumeral arthrosis in young patients is not a novel concept. Several authors have reported satisfactory early results in small cohorts of patients after an extensive arthroscopic glenohumeral debridement and capsular release. Weinstein reported satisfactory results from arthroscopic debridement alone in patients with mild or minimal arthritic change. As would be expected, their results were less favorable in patients with advanced glenohumeral degeneration. Richards combined glenohumeral debridement with capsular release in young patients and reported improved glenohumeral motion and an average symptom-free period of 9 months in a small series of patients. Van Thiel recently reported substantial pain relief in 55 of 71 patients undergoing arthroscopic debridement at a mean of 27 months. Therefore, arthroscopic management of glenohumeral arthrosis will likely not prevent the arthritic progression, but may provide a window of improved pain and function in those with physically demanding vocations. Previous studies have suggested outcomes of arthroscopic debridement are less effective when a large inferior humeral osteophyte is present. Data from our lab has shown that these osteophytes are capable of encroaching on the axillary nerve and could, therefore, potentially affect axillary nerve function. Therefore, we theorize that the axillary nerve is susceptible to a static compressive or dynamic traction injury when inferior humeral osteophytes are of sufficient size. We speculate that osteophytic compression of the axillary nerve can contribute to shoulder pain in some patients in a manner similar to quadrilateral space syndrome. Failure to address this potentially compressive lesion may partially explain the less favorable outcomes reported by some authors when large osteophytes are present. Therefore, osteophyte removal and transcapsular axillary nerve decompression may provide symptomatic relief that is greater than simple debridement and capsular release alone. In this video, we demonstrate a comprehensive arthroscopic management technique that couples an extensive glenohumeral debridement and capsular release with meticulous osteophyte removal from the humerus in addition to an all-arthroscopic transcapsular axillary nerve decompression. Under the appropriate circumstances, a subacromial decompression and subpectoral biceps tenodesis may also be performed. This is an AP image of a 52-year-old very active man who failed non-operative measures. Nearly complete loss of glenohumeral joint space is noted in addition to the large inferior humeral osteophyte. He complained of limited motion, weakness, and posterior shoulder pain. After discussion of surgical treatment options including glenohumeral arthroplasty, he elected to undergo arthroscopic debridement with humeral osteoplasty and axillary nerve decompression. An MRI was also obtained to evaluate the integrity of the rotator cuff and evaluate the inferior humeral osteophyte. As can be seen here, the osteophyte remains within the capsule. Also note its proximity to the axillary neurovascular bundle. The procedure is performed in a beach chair position. It is important to be able to freely move the arm as the full extent of the osteophyte can only be appreciated with arm motion. A C-arm is draped into the field as fluoroscopy is always utilized to ensure complete bone resection. An examination under anesthesia is performed and an ordinary preparation and draping is completed. A standard posterior viewing portal is made approximately 2 cm medial and 2 cm inferior to the posterior lateral corner of the acromion after insufflation of the glenohumeral joint using saline. A standard 30-degree arthroscope is introduced into the glenohumeral joint and a complete diagnostic arthroscopy is performed. A standard anterior portal is then placed through the rotator interval and a 5 mm working cannula is placed. Any degenerative labral tissue or unstable chondral flaps are carefully debrided using an oscillating shaver. Loose bodies are removed as encountered. Chondral borders should be stabilized to prevent continued cartilage slough and mechanical irritation of the joint. Next, a radiofrequency device and shaver are sequentially used to perform a glenohumeral synovectomy in areas where there is relevant hypertrophy. An RF device is used to release rotator interval scar tissue, providing increased external rotation and restoring normal subcoracoid motion planes. If a large inferior osteophyte and posterior or lateral shoulder pain is present on preoperative examination, an axillary nerve decompression and osteophytectomy are performed. The inferior capsular recess is first visualized from the standard posterior viewing portal. Both 30 and 70-degree arthroscopes may be utilized to aid in visualization. Intraoperative fluoroscopy is used to determine and confirm the magnitude of resection. It is preferable to maintain the inferior glenohumeral capsule while the spur is resected to both protect the axillary nerve and minimize fluid extravasation. An accessory posterior inferolateral portal must be created. This portal is located approximately 5 cm inferior to and in line with the posterior lateral aspect of the acromion. This is similar to a low 7 o'clock portal. An 18-gauge spinal needle is used to localize a posterior inferolateral arthroscopic portal. The axillary nerve runs from anterior medial to posterior lateral as it traverses the inferior capsular recess. In consideration of this, it is safest for the spinal needle to enter the inferior recess of the glenohumeral joint near the junction of the medial and central thirds of the inferior capsule. This is just anterior to the posterior band of the inferior glenohumeral ligament. Once the needle is placed for orientation, all cannula are inserted bluntly to avoid injury to the nerve. Only the skin is incised and a blunt switching stick is inserted into the axillary pouch. Dilators are then used prior to placing a 5 or 6 mm arthroscopic cannula. From this posterior inferolateral working portal, the inferior humeral osteophyte is identified and the osteophyte is resected using a 4 mm or 5 mm shielded arthroscopic burr. The inferior joint capsule should be preserved while the bone resection is performed, thereby providing the axillary nerve added protection from iatrogenic injury. The capsule protects the neurovascular bundle and also prevents bone debris from accumulating around the axillary nerve. A curved curette can also be useful to help remove the spur, and a rasp can be used to contour the humerus once the spur is resected. Fluoroscopy is used to confirm adequate osteophyte removal. Internal rotation and extension of the arm allows complete resection of the inferior spur. After the spur is safely removed, a radiofrequency device or handheld punch is used to transect the inferior glenohumeral joint capsule. The capsulotomy begins posteriorly near the cannula insertion site. A blunt trocar can be used for dissection, working proximally to distally to safely separate the capsular tissue from the underlying soft tissues. Blunt dissection from proximal to distal along the course of the axillary nerve helps to prevent inadvertent damage to the axillary nerve as it branches. The axillary nerve is typically encountered near the junction of the middle and anterior thirds of the inferior capsular pouch. The decompression is complete when the axillary nerve is visualized from the subscapularis to the teres minor, with no soft tissue tethering the nerve and no bone impinging upon it throughout its course. Hemostasis should be ensured prior to completion of this portion of the procedure. Once the axillary nerve decompression is complete, anterior and posterior capsular releases should be performed. The anterior capsule is released medially along the anterior glenoid at the capsulolabral junction, allowing for visualization of the subscapularis muscle fibers. Care must be taken to avoid inadvertent injury to the subscapularis tendon. The rotator interval is also released until the underlying coracoid and coracoacromial ligaments are demonstrated. Next, the arthroscope is placed through the anterior portal so that the posterior glenohumeral joint is visualized. A similar debridement and capsular release procedure is performed posteriorly, working from inferior to superior. The capsular release is connected to the inferior release that is completed more safely during the axillary nerve decompression. Using an RF device, the inferior release from 5 to 7 o'clock is extended posterior superiorly. Similar to the anterior release, this capsulotomy is performed medially at the capsulolabral junction so as to not inadvertently damage the laterally based posterior rotator cuff tendons. A subacromial decompression and subpectoral biceps tenodesis are performed in most instances based on the individual patient pathology. The subacromial space is visualized and a liberal bursectomy is performed, thereby reestablishing the normal scapulohumeral motion interface. Unless there is a significant anterolateral acromial spur, an acromioplasty is not routinely performed. Preoperative and final intraoperative images can be seen here. Once it's confirmed that the humeral osteophyte has been removed, the glenohumeral joint is carefully manipulated to maximize glenohumeral motion. Portals are closed in standard fashion and the patient is placed in a shoulder immobilizer. This is a postoperative video of a patient demonstrating glenohumeral motion 3 months after a right shoulder cam procedure. Because of his substantial symptomatic improvement, he elected to undergo a similar procedure on his left shoulder and is immediately postoperative from this. Rehabilitation includes immediate active and passive range of motion. It is critical to maintain motion gains achieved after capsular release and manipulation. Operative regional interscalene anesthesia is frequently helpful to facilitate early therapy, and nonsteroidals are used liberally to decrease inflammation during rehabilitation. Strengthening typically begins 4 to 6 weeks postoperatively based on their postoperative clinical presentation. Maximal recovery is typically seen between 4 and 6 months postoperatively. To date, we have performed 27 CAM procedures in 26 patients. At an average of 20 months postoperatively, we have had a high patient satisfaction rate, decreased pain, increased range of motion, and improved ASES scores. Most importantly to our patients, however, this procedure has facilitated their return to high-demand recreational activities, including skiing and rock climbing. These activities may have otherwise been discouraged after glenohumeral arthroplasty. To date, only one patient has elected to undergo total shoulder arthroplasty. There have been no complications in this preliminary series of patients. Though no complications in 27 consecutive CAM procedures have been encountered, a number of potential surgical risks do exist and should be discussed with prospective patients. Most obviously, the procedure is performed in close proximity to the axillary neurovascular bundle. To this end, the axillary nerve frequently arborizes as it proceeds distally, inferior to the glenohumeral joint. As any number of branches can be encountered in this location, smaller branches may be easily damaged if not appropriately identified. It is also conceivable that excessive fluid extravasation into the axillary space or arm could result in elevated upper extremity compartment pressures or neurovascular compression in a manner similar to retroperitoneal extravasation reported after hip arthroscopy. Expeditious axillary nerve decompression and moderate arthroscopic pump pressures can limit this risk. Finally, as this is a relatively novel procedure, it is possible that scar formation after axillary nerve decompression may result in recurrent symptoms in some patients with longer-term follow-up. We believe that early and aggressive rehabilitation protocols as well as meticulous surgical hemostasis are important to avoid this potential complication.